So I'm going to talk about what we can achieve with coblation in ENT, or certainly within my own practice. And there's probably other things that people do as well, and there certainly are. But just from a personal perspective, to just show you the kind of things that we can use it for. Now, as a declaration, I've given some instructional lectures for Arthuricare originally, who owned the coblation technology, and then subsequently Smith and Nephew bought out the company. And I've offered once some product advice, but otherwise I've got no conflict of interest. I don't have any financial interest in the companies in any way. So talking about surgery and what we can do, we've got to think what a surgeon is. Now, a surgeon is someone that works with their hands, from the two Greek words for hand and for work. Now, of course, with your hands, you're relatively limited in what you can do. Of course, you can handle tools, but with just your hands, you're rather limited to palpation, massage, osteopathy, and manipulation. And this is Sushruta, who's credited with the first documented surgical practice in 600 BC. He was a cosmetic surgeon. Now, of course, as well as our hands, we've got to think about other things we can use. So broadly speaking, we can use for surgery, apart from our hands, cold instruments or powered instruments, which are either hot or cold. You could also use non-powered instruments, for example, just hot irons and so on. So let's not forget our forebears. We don't use those in modern practice anymore. But, the kind of things like microdebrider, the knife, laser, these are very commonly used in ENT and other practices. Now, with the Star Wars theme that Ishan's very keen on, it's really important to look at the potential things, because there are parallels within surgical practice. It's not just a smooth slide. So of course you've got a laser, and this is actually the Death Star laser is called, I'm pretty sure, a mega laser. So it's not just a normal laser, but a mega laser. And the public perception is that lasers are surely the most fantastic thing that there is. But there are other things which are very useful. Now, on the bottom left, those eagle-eyed viewers might recognize that as a blaster set to stun. In the fourth episode of Star Wars, the first film, A New Hope, when Darth Vader and the stormtroopers board Princess Leia's ship, they set their weapons to stun. And this is the only instance in 12 or 13 Star Wars films, or however many there are, that any weapon's been set to stun. So that's what you have. So you essentially have an instrument which is used in that situation in a much more gentle way than normal. So instead of killing someone, they just knocked out. Now, of all the instruments though in Star Wars, all the weapons, the one that is most pertinent to our discussion tonight is the one on the right. Now, again, only an expert in Star Wars might recognize this, but this is on the Hoth system, part of the Empire Strikes Back, and this is an ion cannon. And this is used by the rebels when they're fleeing the Hoth system to blast their way through Imperial ships that are straight in front of them, to clear a path for their own ships to escape. So that's an ion cannon. I'll come to that later. So actually it comes to that quite quickly, because the coblation technology has parallels to that. So a radiofrequency current is passed through the tip of this wand with a saline medium which dribbles out, and the electric current passing through the saline sets up a plasma field of ionized particles, so free radicals, which then can be used to bombard the tissues. And this is an ion cannon of your very own. So this works at 40 to 60 degrees Celsius. And in fact, it was developed back in the 1950s, and it was initially marketed in orthopedic surgery by Arthuricare, hence the name of the company, and has been used in ENT practice from the 1990s onwards. And we'll talk later, it's got FDA approvals for tonsil surgery and other things. So it's your very own ion cannon. Now, in terms of thinking about surgery, you've got to think what our ideal operation is. And really, the ideal operation is a tug of war between, on the left side, efficiency and efficacy, and on the right side, safety. Everyone wants an operation that is effective, efficient, and safe. But of course, it's difficult to strike that balance. Now, operations should also be simple as possible, keep it simple, and also generalizable to as many people as possible, because you want everyone to be able to perform simple procedures well. Ideal operations should have no pain, should have no bleeding, should have be associated with no loss of function, and also no morbidity or mortality. And of course, you can get close to these things, but often not completely right up to them, but you can make a good attempt. Now, in surgery in general, tonsil and other simple surgeries have parallels to our general considerations in surgery. So what we as surgeons are thinking about is not necessarily what the patient wants. So the lady, the patient here, wants, like most patients, a safe operation with an easy recovery. Whereas the surgeon may be thinking, well, I can offer you a safe surgery, but I'd rather perhaps give you a slightly riskier one, because then it keeps my figures right and I don't have recurrences and I don't have this and I don't have that, even though you might have more pain with it, even though you might have more morbidity. So we've got to think, are our interests in terms of the surgery aligned with the patients? And it's not always the case. So things as well to do with ENT are that we work in functionally essential areas of the body in terms of breathing, swallowing, speaking, for example. We've got to think straight away, does the patient need surgery? And also, how important is it that they recover well? There are potential problems in the event of scarring in terms of loss of function. And these areas that we operate on are richly innervated, they're highly vascular, and we share the airway with the anaesthetist. So these are all really important considerations. Now in paediatric ENT, we've got to think to ourselves, how important are our surgeries? Well, the answer is very, very important. Apart from dental extraction, where there are in England about 80,000 operations a year, tonsillectomy is the next one in the league. So almost 32,000 tonsil surgeries were done in England 2015 to 2016. In the UK as a whole, in children, probably approaching 40,000 operations. So it's a big deal. If you compare that to other common ENT procedures, they're much of a muchness, but then compare it to the flagship operations, cochlear implants, microlaryngobronchoscopies, airway reconstruction, then it come close. So we've got to get these simple operations right. The reality is that not everyone having a tonsillectomy or adenoidectomy or a set of grommets can go to a specialist in tonsillectomy. They have to go to their nearest ENT hospital often. And that means that the people working in those centres have to be able to offer surgery which is safe, efficient, where the patient recovers well, and where you reduce complications to a minimum. And that's to be generalisable throughout the UK or throughout the developed world, not just in specialist centres. Other things to think about, when you're operating a lot of patients, and more than 30,000 patients a year, as ENT departments around England are, you've got to think to yourself, risk of things going wrong is a multiple of hazard in terms of what's the chance of something going wrong in a particular case, multiplied by exposure, how often you're exposing yourself to these potential risks, or how often your patients individually are exposing themselves to these particular risks. So though serious complications such as heavy, torrential hemorrhage and death, for example, after tonsillectomy are rare, overall, they do occur because you've got enough hazards, you're exposed to enough cases. Now, the other thing that people often confuse is that the risk of complications of an operation is not the same as the risks, in inverted commas, of recurrent symptoms. Complications aren't the same as recurrent symptoms. Complications are bad things that happen straight after an operation or soon after an operation, or long-term problems because of what you've done. Limitations or recurrent symptoms are what you had originally, which hasn't necessarily been cured, and they're two different things. So it's important to think about the difference between limitations of surgery rather than the risks of recurrence. It's not really a risk, it's just a possibility of something occurring or continuing to occur despite your intervention. Now, in terms of coblation, what we have to do is compare this technology to use of other instruments and approaches in our field. Now, you've got to think, for example, the efficiency of the surgery, how quick it is to do, how easy it is to deliver, how long it takes to do the operation. You've got to think about intraoperative bleeding, postoperative bleeding, the potential for soft tissue injury and swelling, recovery time for the patients. And also we've got to think about effectiveness long term. Does it work? Do the symptoms resolve? And is there a risk of mortality? Now, remember, tools that we use are only as good as the surgeon. So we have to bear in mind that to use instruments safely, whether it's a knife, a pair of scissors, a curette or a coblator, you need to know how to use it properly. And that comes from practice and being careful. And that's just Sir Lancelot Spratt, who is a character from Doctor in the House, a fantastic film from the 1960s. And he was a very domineering man. And he said to his medical students, don't forget, to be a successful surgeon, you must have the eyes of a hawk, the heart of a lion, the hands of a lady. And he's asking the medical students, what do you come across next after going through the skin? They say subcutaneous fat cells. He said, what next? Come on, spit it out, man. Blood, you numbskull. So that's what we have to avoid, bleeding. Now, the other thing is when you're talking about use of particular instruments, like in my case, I'm talking about use of coblation. it's quite easy to fall into the trap, which is the cognitive bias proposed by Maslow and Kaplan, that when you have a hammer, everything looks like a nail, and you're trying to make an operation to fit your technology. And it's important to get that across. That's not what I'm trying to put across to you this evening, or in general. It's an instrument can be very useful, but it has its role, and it has certain situations where I don't think it has a good role. So in terms of surgery, we can offer a variety of ENT procedures, including tonsillectomy, adenoidectomy, reduction of the lingual tonsils, or even the muscle of the tongue base, but I haven't done that myself. There are the possibilities of laryngeal procedures and also turbinate reduction. It's important that the company has certain operations which it validates its equipment for use in, and others use kind of off license, as it were, but they have their own role in certain situations. So let's talk about tonsil surgery to start with. Now, to understand tonsil surgery, we need to look at the pioneers, and in fact, people have been doing this for more than 2,000 years. Celsus was the first to describe finger dissection tonsillectomy, and Aetius of Amida discussed partial tonsil excision, recognizing even then, 1,500 years ago, that traditional tonsil surgery was potentially dangerous. Now, in terms of modern pioneers, guillotine tonsillectomy became very popular in the 1800s. Largely, it's an intracapsular technique. The tonsil is crimped with a guillotine, and you leave a little stump behind, and it basically chomps through the tonsil tissue. And this was initially by the work of Philip Singh Physic, a surgeon in Pennsylvania, and then Hunter Mackenzie in the UK, using various types of guillotine. Now, total tonsillectomy, as in what we class as normal traditional tonsillectomy, became popular again in the early 20th century, and largely due to the work of George Ernest Waugh and some other colleagues. So Waugh described 900 cases, which he published from Great Ormond Street, with chloroform anesthesia and a 3-minute average operating time with no complications. And I have to confess that even with modern techniques and modern anesthesia, I can't match those, or I don't know anyone with real results these days that can match those complications. So quite an impressive series, I'm sure you'll agree. Now, as time has gone on, it's interesting that between the time of war and modern times, very few published studies ended up looking at tonsillotomy or intracapsular tonsillectomy of any sort. It very much went in our specialty towards traditional, what we call traditional extracapsular tonsillectomy, for a variety of methods, cold steel or hot methods. And with time, the indications have changed in terms of pediatric tonsillectomy from patients with recurrent tonsillitis down to more patients with obstructive symptoms. And with the advent of increasing recognition of patients with obstructive sleep apnea being also warranting surgery at a younger and younger age, we've been operating on higher risk patients. Now, in terms of tonsillectomy, things we have to be aware of is there are various methods, but they're typically, or they have been typically extracapsular. This exposes the muscle and blood vessels, which gives you edema, pain, and a significant hemorrhage and mortality risk. Now, although the risk is widely described in the literature between 1 in 7,000, 1 in 170,000, we would probably say in the UK, it would occur probably about 1 in every 50,000 patients, maybe up to 1 in every 100,000 patients. This is broadly speaking, the risk is that you will have a tonsillectomy-related death in children in the UK every year to 2, something like that, maybe 1.5 years to 2 years to 2 or 3 years. Now, this has obviously catastrophic implications for all concerned, but also has wider implications for the specialty as a whole. Your flagship operation, the second commonest in children, can kill your child. It's a very significant situation. My child had tonsillitis, now they're dead. You know, that's a big deal. So it demands our efforts to reduce these risks to a minimum. Now, what can we learn from other countries? Well, about 15 years ago in Austria, there were 5 hemorrhage-related deaths reported in under 6s. And this is a country with a population of 8 million people, not dissimilar in terms of healthcare to the UK, and actually where only 4,000 to 5,000 paediatric tonsillectomies are performed per year, so commensurate with the number performed per population in the UK. And this then prompted a major shift towards intracapsular surgery, which has been mirrored in Scandinavia. Now, when we're talking about the tonsils and the risks of bleeding, we've got to look at the anatomy. And this was a cadaveric study done in South Korea, looking at 15 adult cadavers. And they looked quite specifically at the area around the capsular plane. And I don't know if you can see my cursor, but the small vessels north of that line are within the tonsil, small arteries and small veins. And what you see outside the tonsil capsule is much bigger arteries and much bigger veins, even a millimetre or two outside the capsular plane. And this means that the vessels are bigger and consequently, they will have a bigger flow rate. So if you expose or injure those vessels, they're going to bleed and potentially, as you know, very heavily. Other considerations, the tonsil tissue is lymphoid and doesn't contain any nerves, whereas the muscle and mucosa are richly innervated. And scarring at the extracapsular plane will often make the separation of the tissues very difficult. Now, this is a real clinical scenario. This is a child I looked after, not his clinical photograph, but he had severe obstructive sleep apnea, severe recurrent tonsillitis, age 2, weight 14 kilograms. And he was on the Fontan pathway for hypoplastic left heart, on aspirin, and lives remotely outside London. So you see a child like this, and the cardiologists say, please, can you remove their tonsils? And it fills you with horror, because you think, what if this child has a heavy bleed when they live outside London? Do you have to keep them in for 2 weeks? It's a big deal. So then you've got to think to yourself, what options do you have with tonsillectomy? Well, you have the option of traditional extracapsular tonsillectomy, a very partial tonsillectomy, as we've seen in the literature. I tend to prefer the term intracapsular tonsillectomy, which can be partial or total. Now, the pioneers of intracapsular tonsillectomy latterly in the 21st century have been Peter Coltai and Elizabeth Hullkrantz, using a variety of techniques. And a lot of our work is based on their findings that these were associated with fast recovery and low risks of complications. Now, coblation-assisted intracapsular tonsillectomy has an established FDA approval, and of course the instrument has been used for extracapsular tonsillectomy, but I have no experience of that myself, so I can't comment about it particularly. I mean, all the studies are there for you to read in the literature. But there's minimal data so far published looking at use in patients with tonsillitis, for example. It's mainly considered to be an operation for people with sleep apnea. Now, I was saying before, what do we think and what do patients think? Well, it's often two different things. So we think as surgeons that if we leave tonsil tissue behind, then patients are bound to get tonsillitis if they've already had tonsillitis. We also think that any residual tissue is going to be associated with persistent or recurrent symptoms. And there is also the belief that's firmly held, despite many people, or the majority of surgeons in some areas, not following up their patients routinely, that traditional tonsillectomy eliminates sore throats. That's simply not true. And actually, very, very few studies have looked at long-term outcomes after tonsillectomy, say for tonsillitis, but actually a reasonable proportion of patients will have some symptoms. There is also the notion that revision surgery is the same as a serious complication, which of course it isn't. If you had to do revision mastoid surgery as an expert otologist, you wouldn't be considered to be a charlatan or a clown. That's part of your practice. The same for an expert rhinoplasty surgeon. 10% of their patients may have revision surgeries. That's much different to resecting half the septum and giving the patient a saddle nose. That's incompetent, whereas having the need for revision surgery is just part of surgical practice in general. And also there is the thought that patients will complain if they have to have a revision surgery, but that's not the case. Now, in our practice, working with this method, it's something I wasn't exposed to at all as a trainee. It wasn't really done much in the UK. It hadn't been published. We started with a small number of patients. I was working in parallel at the time with Nico Jonas, who now works in Cambridge. And we had a few patients who were a bit dodgy. They were small, they were high risk, and they weren't really considered good candidates for traditional extracapsular tonsillectomy. And we had success with them and widened our applications to older children with recurrent tonsillitis and so on. And this really mandated prospective case-by-case audit to make sure the surgery is safe and acceptable and it works. And we published our first 100 patients. So we're looking at young children in a tertiary centre with a mixture of OSA or tonsillitis. Now, it's important that with these results, these are either consultant performed or more commonly supervised trainee performed. And that's the importance of careful supervision, learning how to do things well, and being a bit nitpicky, even with what's considered simple surgery, because you have to get away from the fact that tonsillectomy is not just an SHO operation or registrar operation, have a list when the consultant's not there. They're operations which can work really well, but can go extremely wrong. And you need to have a decent degree of supervision to make sure it's done properly. We give all the patients regular simple oral analgesics and antibiotics. And we started right from the outset using prospective T14 questionnaires. And our surgery became quite quickly much more comprehensive, quite partial to being much more total intracapsular. I'll show you all about that. So this is the Coblation wand we use, in this case, the ProSize Easy View wand, and there are other variants. And this is the electrosurgical generator on the right, produced by Smith and Nephew. Now here's the surgery, so I'll run through this. So, and we'll talk about the results with tonsillectomy and so on, but I'll show you some other operations you can consider. So this is a patient who was having, interestingly, you'll see on the left, just moving on, we've done a small biopsy, taken a chunk of tonsil off to send to the lab. This is a post-transplant patient who's had a renal transplant before. So they've had a small lymphoid tissue biopsy. And this is how the wand works. So you, with the non-coblating hand, you use a Mollison pillar retractor to just support the tonsil to bring it into view. And using the coblator on standard settings, it dribbles a little bit of saline and it ablates the tissue away. The ion cannon, so it basically just dissolves the tissue at minimal penetration, 100 to 200 micrometers depth, and it's extremely gentle. You see, essentially bloodless, and it's not charring or burning, and you've got a lot of control. So now I've got a small forcep closed to just tether the tonsil a little bit and just act as a guide. The instrument is bipolar, so it doesn't arc against the metal, and you can use that non-coblating hand to just tether the tissues exactly where you want. You can see minimal associated trauma. You make everything nice and flat with the surrounding tissues, and you can cauterize the base a little bit to try and reduce the risk of the tissue regrowing. So that's the left side done, and then you'll see the right side. Now, of course, this video is speeded up. With practice, you can do a tonsil surgery quite happily in probably about 10 minutes. It's very quick. I mean, it doesn't need to take ages. So we give gas or IV induction with these patients. I tend to use endotracheal intubation. I find it more difficult to use a laryngeal mask airway, but a lot of colleagues do in other centers. We use decongestant drops. We use paraffin around the lips because the coblator can often rub on there. And we use intraoperative IV paracetamol, diclofenac, and low-dose fentanyl. And post-op, we just put some topical levobupivacaine. And some patients need one single dose of oral morphine in recovery. But afterwards, it's very simple analgesia after that. It's not a painful post-op course. And these are the kind of views you have before and after surgery in a particular patient. And this is a picture of a child who had surgery when he was 11 months old for severe sleep apnea with massive grade 4 tonsils. And this is the small residues you see, a little fullness each side. When he came he had revision adenoidectomy actually, and because he still had some sleep apnea. But you can see how well the tissues have healed, all nice and supple. There's no scarring. There's no box-shaped kind of scarring that you sometimes get with traditional surgery. So the first 100 cases, we insisted on a return to school after 2 weeks, just like normal tonsil surgery. But the reality is that many parents said their children were driving them crazy at home by being so well and running around that they just sent them back to school or nursery. And so we adopted a more relaxed policy. And now I just let them go back whenever they're ready, which is often very, very fast. So this is the T14 questionnaire, which is available through the ENT UK website and other sources online. It's approved for audit use by ENT UK, so you don't need ethical approval to use it. We use it pre and post-op for all the patients. And almost everyone is very happy to complete it. I've only had maybe 1 or 2 refusals in about 1,500 cases. It's not normally an issue. Oh, I'll just say, I mean, the first 6 domains are obstructive domains, and then the second 8, the remaining 8 domains are infected. So it gives you a total score out of 70. And we published our first 500 cases a couple of years ago now in Clinical Otolaryngology, and you can find that. And we've submitted another series now that's currently under review, again with Clinical Otolaryngology. So this is the latest results. So now I've operated on in my own practice, but I mean, this again is me operating or consultant supervising trainees in my own patients. 1,500 patients between 2013 and 2020, and we've completed follow-up with pre and post-op data, which we submitted for publication, 1,257. A small number had either no pre-op or no post-op questionnaires, so they were excluded from the main analysis, although they didn't have any other particular problems. Only 4 patients were truly lost to follow-up in parallel with these ones, and the remainder are waiting for follow-up and or data analysis. But broadly speaking, complication rates in the remainder have been proportional to the ones already studied, so there's no sort of hidden results. And this is with very, very accurate follow-up, so we're not missing patients. So in terms of demographics, I'll run through this in the interest of time relatively quickly, but these are patients in a tertiary centre. So you have a range of ages from 6 months to 18 years. Importantly, about 40% of patients weigh 15 kilograms or less, and they all do really well. And about 11%, in addition to sleep apnea, have got major comorbidities, syndromes or major issues in addition to their diagnosis. So broadly speaking, about 2/3 of the patients have had just sleep apnea as a reason for intervening. About 40% have had a combination of sleep apnea and tonsillitis, and a small number, probably only about 5%, have had just recurrent tonsillitis. They're actually not that common, those sorts of patients. There's often a bit of snoring or something else going on. Now, all the patients that we looked at, 1,257, we only had 3 postoperative bleeds requiring readmission. And in the other group that haven't yet been analysed, I know of one other case where there's been a small postoperative bleed requiring the briefest of readmissions. I mean, it's a tiny trivial amount, but the local hospital admitted them anyway. So you're looking at essentially about 1 bleeding episode requiring readmission every 300 to 400 patients. And that's very, very accurately looked at. So we're not missing large volumes of patients or anything like that. So it's a prospective study with everyone followed up. And these bleeds occurred at random times and so on. One other child was readmitted for 1 night with a respiratory infection. We also had one other patient that came in for brief review who had quite a fat uvula that kind of got a bit swollen, and the local doctors got into a panic, but that will settle. Recovery time, most patients require analgesia for about 5 days on average, back to school or nursery within about 6 days. More than 99% eat reasonably well on the day of surgery. None had delayed discharge because of pain or other tonsillectomy specific complications. So of course there are a few patients that have to stay in a little bit longer because of breathing related issues or the kind of things you see with patients with severe symptoms pre-op, and no patients at all were readmitted for pain. And these are the T14 scores. You drop from about 30 out of 70 total to about 3, and this is with follow-up of almost 300 days. So about 10 months mean follow-up. This is direct follow-up on average, ranging from a few weeks up to several years in some cases, where patients have come for long-term review or come to about their grommets or something like that. We run more tests, more T14 scores with them. And this works well across obstructive and infective domains. Recurrence rates people ask about, that's broadly speaking affected 2.7% of all our patients. And bearing in mind, we're dealing with a lot of young and small patients. 27 of these patients have recurrent sleep apnea. Sometimes the tonsil residues that we revise can be very, very small. Same for the adenoids. A little bit of regrowth can cause quite a bit of symptoms for some of these more severely affected children. And 6 patients out of the 528 that have tonsillitis and indications, only about 1.4%, have had remnant tonsillectomies using bipolar. So very, very few. And if you compare these figures to the number of children who would be readmitted to hospital following traditional surgery or have to have emergency procedures to stop bleeding and so on, this is actually fewer in number than what would occur with traditional surgery. So big risk factors that we found looking at regression analysis for recurrence of OSA at age 2 or less at the time of first surgery, and those children had severe sleep apnea. Almost none of the patients having recurrent symptoms have no other things on their rap sheet. They're either very young or they have severe symptoms to start with, or they're syndromic or something like this. Tonsillitis recurrences occurred at different age groups, and we found that low weight and comorbidities are not obvious risk factors for revision, nor indeed for postoperative complications. On the subject of tonsil surgery, the Getting It Right First Time multi-center audit has been published. It was published last November, and this looked at a variety of specialties, particularly in ENT, looked at a variety of operations and other domains around in terms of ENT practice within the UK. 126 trusts in England managed children and adults, and they were included in the study, and this covered almost 50,000 paediatric and almost 23,000 adult tonsillectomies. And they looked at 30-day all-cause readmission after tonsillectomy. Now, this tracked the patient via their unique NHS number. And so all the patients that were readmitted to hospital could then be tracked, and it was known for definite what happened to them. So unlike other audits which have been previously done, which required self-reporting, these were done completely independently with a great deal of effort, but with very, very tight data. Now, this showed that the average return to hospital, readmission rate to hospital for children in England is 8.5%. That's about 1 in 12 children, and almost 20% in adults. These are frighteningly large figures, and it does fill you with some dread. The commonly peddled notion of 2 or 3% of children, or 2 and 3, 4% of adults just coming back to hospital is simply not true. And this is very, very robust data, which stands up to any sort of scrutiny you wish to throw at it. Now, interestingly, during this period, our readmission rate at Evelina was 3.5%, but that included quite a lot of patients that were still having at that stage bipolar tonsillectomy. I've been happy using coblation for patients with recurrent tonsillitis, coblation intracapsular tonsillectomy, for a long time. But even with about a third of our cases being done with bipolar tonsillectomy, we still had the lowest figures for readmission of large centres in the whole of the country, which was a marked outlier. And interestingly, if you look at just our coblation cases, of which 2/3 were coblation intracapsular, the readmission rate for those was just 0.4%, so about a 14th of the national average rate. It's very, very significant. I mean, you can't match that in any other way. And this is the data all plotted on a scatter plot, with smaller centres on the left, larger centres with more cases per year on the right. The black line is the average, or the mean readmission rate, about 8.5%. Down at the bottom right is our total readmission rate with tonsillectomy, and this is what was plotted in there in the study. So you can see it's a marked outlier compared to all the others. And then if you look at the coblation only cases, which I'd put in myself in pink, those show the intracapsular tonsillectomy readmission rates are absolutely tiny and a dramatic outlier compared to some of the other centres. Now, this study looked at 1,147 episodes, patients coming through our trust in about a year and 4 months or so. So 2/3 and 1/3 were intracapsular versus bipolar extracapsular at that time. Now we've moved very much more to just intracapsular now, but with a few bipolars here and there. And our total readmission rate for bleeding particularly is 1.5%. The total return to theatre rate was 0.2%. And interestingly, if you look at the differences in bipolar versus coblation intracapsular readmission rates, they're quite significantly different, almost 8 to 9 times different in our centre, with everything else matched, same experience of surgeons, etc. So very, very different, even in this sort of controlled group. Now, really, really central. I mean, you've heard from my lovely colleague Lily, and I've also got some other fantastic. I'm very happy with all of my, to work with all of my colleagues. What's been really fantastic in our centre is this has been an approach which we've all started to use based on dialogue, based on working well together. There are a few centres where everyone does the same sort of thing, and that generally comes by, well, everyone does the same good thing, hopefully. I mean, there's places where, people aren't necessarily doing good things universally, but actually doing something that works well, that is good, relies on a team approach. So you need this sort of approach to give us an excellent environment for learning, to make progress, and so we can incorporate or indeed reject new practices and ideas. And also we have team-based governance. And if things are not going quite well with certain people, we can chat about how to make things better using these techniques which we all use. And it's absolutely can't be overstated. So although I'm presenting to some extent some of my own data and so on, the GIRF data has been fantastic in showing that actually this is the practice that's almost translatable across our whole department and between trainees and consultants and whoever else. So discussion points, we'll finish up with tonsils now, and I'll touch on some of the other things. This is the largest prospective UK series, and I've shown in my own data, but also the GIRF data is showing very, very low hemorrhage rates compared to national data. Parents are generally very satisfied, and children can go back to school really quickly, and generally it works well long term. Now, it's really important that patients are properly selected, and we can talk about that in the questions at the end. Informed consent is obviously vital as well. There's an initial learning curve to make sure the surgery is efficient and you can remove the tissue right up to the capsule. And the one's extremely powerful. You can injure other structures if you're not using it carefully. Other tips, of course, you've got to aim for a perfect outcome. So this is not the same as just, this is a registrar training operation, which you just kind of look the other way or go and answer some emails. With practice, it can make a really, really big difference. I'm saying that in a flippant way. That's not my practice. I'm talking about, what we have sometimes traditionally seen within our training. You need to have a careful and consistent approach in managing trainees and managing colleagues learning these sorts of methods. And we always try and keep practicing, keep learning. Things I learn from the trainees with regards to this kind of surgery, things I learn myself by practicing. So this has intracapsular tonsillectomy using coblation has major potential advantages to reduce recovery, pain, and complications. There is a limitation in terms of regrowth and symptom recurrence. And of course, we need further studies in larger series to conclusively demonstrate benefits over other techniques. But of course, this is also something which is generalizable with relatively limited training to large numbers of cases through the UK and elsewhere. Now let's talk about other operations. Now this is adenoidectomy using coblation. So this is a video very kindly offered to me by Nico Jonas. It's quite difficult to video an adenoidectomy, but this is how we use the coblator. So the patient has the palate suspended with a Jakes catheter, in this case a suction catheter, and the coblator is just used to plane away the tissue at a similar level. So you can see the choanae on the right and the left as you're standing on the adenoid tissue, as it were, or the nasopharynx, looking forwards into the nose with the turbinates on either side. And you see that the coblator makes short work of the tissue. It's almost a bloodless field. You just hover there, and the saline dissolves the adenoid tissue away beautifully. And actually, this is probably a little bit slower than normal. This is taken with a 120-degree endoscope rather than using a mirror like we normally do. But it's a beautifully dry operation. It takes a bit of practice. And again, if you clobber the septum or the turbinates with a coblator, it can bleed, but with careful use, it's super gentle and recovery is excellent. Less charring, probably less smell than with some of the other hot techniques. I'll move on in the interest of time. Now, this is another way you can use the coblator. So with time, we've started to use this more and more in the larynx. So you can use it for papillomas, and that's what you'll read about sometimes in various articles. But this is a use for a patient who's had a big subglottic cyst, who's intubated near birth. And you've got quite a sort of diffuse cyst, which doesn't lend itself very easily to being plucked off in a normal kind of cold steel fashion. But with the coblator, sure, you get a little bit of laryngeal spasm here and there. And I've sped up the video to just kind of go through it a little bit more. But essentially with the ablation mode, you can deroof the cyst really nicely. And you'll see later on, with almost no blood or collateral injury, expose the base of the cyst and cauterize it really, really nicely. And at the end, you'll see the video will slow down and see beautifully what you're left with. And this is one of my trainees doing the surgery. And I was, I don't think I was doing anything. Maybe she was, I think, videoing and doing all the surgery herself. It's very, very straightforward. And you can avoid injury to other structures. And that's what you get at the end. This child went home later that day, without any trouble, went home to Kent absolutely fine. This is an Arytenoidectomy. So this is a child who's had a laryngotracheal reconstruction before and has this scar band there at the back where we've placed the cartilage graft. This child was born at 23 weeks gestation, intubated and ventilated for about 4 months at the start of life, long-term oxygen dependence and so on. And this is her situation after laryngotracheal reconstruction with rib cartilage. Now you can see that the cartilage knuckle of the arytenoid on the right is obstructing the airway a little bit. And so you can use the coblator. Again, this is the microlaryngeal coblator, and it's very, very gentle. So here it is. And this, again, this is one of my trainees. I think she was doing this surgery and I was just watching her doing it. So it's something very, very easy to supervise. This patient has 100% oxygen. You don't need to drop the oxygen level. She's got very, very poor functioning lungs. So having smoke from a laser, having to fiddle around with the laser settings and also the oxygen settings would not be an option for her. So again, this just carries, hang on. Yeah, it's just a big video, so it's taking a bit of time, but it'll move on. I'll leave it there rather than trying to fiddle with it. But essentially, we then dissolve away the tissues, the knuckle of arytenoid, and you keep going, keep going, keep going. Let's see, I'm going to take a risk and try and move the video on. Let's see if it boots up. Yes, so this is the picture at the end. So it looks a bit tatty, but essentially taken up quite a big knuckle of cartilage. And you can see with almost no injury, this is 2 weeks later when she came for a follow-up. So you see how beautifully it's healed. That knuckle is completely gone. There's minimal granulation. This is completely untouched. It's just how it looked as soon as we put the telescope in. Nothing really to do. Looks great. Now, this is a patient who has had failure with, has had adenotonsillectomy before for severe obstructive sleep apnea. Still has massive lingual tonsils. And these can be a bit of a challenge to remove, but we do the lingual tonsil reduction with the nasal tube, which you can see in a reinforced nasal tube. I think this is a laser tube. You don't really need a laser tube. You just need a nasal tube, a cuff tube. And you see the epiglottis hiding there. And we use an anesthetic laryngoscope with an assistant holding the telescope. Again, I think this is, again, me holding the telescope. and my colleague, one of the trainees doing the surgery. So we start around the epiglottis and use the blade of the laryngoscope to just bring everything nicely into view. Again, it'll load up. I think just a little bit temperamental. Here we go. I wonder if my wife might have started watching TV or something like that to slow the internet down. But anyway, let's see. Just a sec. Strange, yeah. So this makes short work again of the lymphoid tissue, and you can protect the epiglottis pretty well. It does get a little bit of mucosal injury here and there from the saline dribbling onto it, but it's not something to be frightened of. So this is sped up a little bit, just in the interest of time, but you can see it makes short work of the lingual tonsil. And we're not in the tonsil, so we're not in the tongue muscle there. This is just lingual tonsil tissue. You can see that nice honeycomb structure. And this is just, you just take it, you find the epiglottis, find your way away from the epiglottis so you're not injuring it again and again and again. And with the anesthetic laryngoscope, you can really see exactly what you're doing. And you can move around and move around, whereas other methods where you have, say, rigidly fixed laryngoscope, it's much harder to see in there. And you keep working your way around. And I'll try and show you at the end what you're left with. And this child, believe it or not, went home like most of the others the same day. They eat normally, some of them eat, burger and chips for lunch, very comfortable speaking normally because you haven't injured anything. You haven't injured the muscle, there's no heat, you haven't used monopolar, you haven't barbecued the, you see robotic surgery for lingual tonsil reduction and the patients are in absolute agony at times, whereas this is very, very gentle. You can use this for the turbinates as well. I haven't got any good videos myself of turbinate reduction. It's essentially you do it like an SMD, but with a finer and more gentle probe. It achieves minimal scarring, very occasional granuloma formation where but again, this is rather than using linear cautery like some people would do with an Abbey needle, you just do it all intra-turbinate. It's very, very gentle, easy and effective, takes a few minutes. You just decongest the nose before the operation, do adenoidectomy or whatever. This is for little children with sleep apnea where they've got big turbinates. Very, very easy. So conclusions then, and then we'll have time for questions. Coblation is potentially an excellent instrument for intracapsular tonsillectomy and for adenoidectomy and a variety of extended applications in the airway. It has potential advantages over other surgical modalities. It's easy to use, easy to learn. It allows you to ablate the tissue in a very controlled fashion with minimal collateral injury and rapid healing. So offering you almost a perfect operation.
So one of the questions that has come up is what setting do you use for the inferior turbinate reduction SMD?
Standard setting comes, it appears on the wand, on the machine. So when you plug the device in, it will just set to its standard, which is 4 for ablate and 2 for coag with the wand I use. There may be different settings on some of the other turbinate ones, which I'm not familiar with, so I don't use them. But on the Paediatric one, 4 and 2.
Brilliant. He says, thank you very much. And I guess one of the things, any impressions for adults?
For adult surgery?
Yeah.
Yes, so adult tonsil surgery, again, it's one of those operations where people just say, well, look, it's going to be awful. You've got to have 2 weeks off. It's awful. It's awful. You might bleed. It's really bad. And it's completely negatively perceived. Now, some of those patients will have heavy bleeding. Some patients have massively heavy bleeding and they require things like transfusions, readmission to hospital and so on. You can use intracapsular tonsillectomy with adults. Now, the recovery is a bit more variable in children. It can be really fast. I've had some patients I've looked after about 130 adults with intracapsular tonsillectomy for a variety of indications, largely tonsillitis. Some patients recovered well enough. I mean, one of the patients I looked after, she went out for a meal with her husband that night and had wine for dinner and various things. So recovery can be really fast or returns to normal exercise within 24 to 48 hours. Other patients will struggle into a second week. We've had a couple of patients have had quite bad pain, but most of the time they recover pretty well. But the bleeding rate is a big deal. So the only patient I've had that's been readmitted to hospital with significant bleeding, which was still managed conservatively, was a haemophiliac. And actually I've looked after her and both her daughters, all with the same indication, they're all haemophiliac. And they've done really, all 3 of them have had tonsillitis and they're all fine. So she was she was readmitted after a few days, but again, managed conservatively. Now, of all those patients, one patient's had revision surgery and a couple are in line to have revision surgery. So that's 3 patients out of about 130, just over 130. So broadly speaking, maybe 1 in 45 patients. Or maybe just over 200. So it's not huge numbers, but it's worth bearing in mind. But again, it's the patient's choice. What we think of as a disaster, they may think of as a reasonable, limitation, but they're happy to take that on the chin. If in the majority of cases that they have been, they can do really well. I've followed some of these patients up for five or more years, and they're generally really happy, although there are a few with some grumbling symptoms.
Great, thanks, Dan. There's another question about intracapsular tonsillectomy for recurrent tonsillitis, which you've answered. And there's a few more questions. There's a question, how do you establish a plane of dissection in intracapsular tonsillectomy?
Well, there isn't a plane really, because you've got to dissect down to a level, but it's a bit like if you're doing mastoid surgery, you've got to have an appreciation of, things that lead you to work out, for example, where the tegmen is, the bone, the quality of the bone changes, the appearance of the blood vessels changes, and you think, right, I'm coming towards it, and you slow down at that point. A bit similar to that. So you take things on a broad front, and the Maltesery kind of quality, or if you're familiar with British and American confectionery, but the Malteser kind of appearance of the tonsil will be quite yellow, and it becomes a bit less yellow. You see some whitish tinge or bluish tinge of the capsule underneath, and you drop the settings to a lower level. And when you get down towards that base, the coblator on a lower setting shouldn't make a hole in the capsule. Again, you've got to be careful you don't go around the edge of the capsule and injure the muscle that way or injure other structures. But you generally, with a bit of practice, get the idea.
Great. And Ali Al-Lami, he's one of our consultant colleagues, is asking, what are the common problems intraoperatively that you encountered when you started the service in terms of setup, etc.?
It's a bit fiddly to set up. I mean, one of the things that they have is a flow regulator for the saline. So the saline tubing, the giving set, like for saline to give an IV, goes through a little flow regulator that just pumps the fluid round. And that's, just need to know how to set that up. You need to get approval for using the equipment in your hospital. Luckily, we had it already, although it hadn't really been used very much, and we're lucky we could just start using it without too much trouble. But it hasn't, it's got established use. It's actually highly recommended, in the GIRF report. It's something you can use with a big kind of pat on the back. You shouldn't really need to ask someone's permission to do an operation, which theoretically is much safer than one you're already doing. So from that point of view, it's relatively straightforward. There's some cost implications, but again, the high day-case discharge rates and tiny risk of readmission more than offsets the cost of the one, which is about, in the UK, about £140. Other things, just have to learn how to use it. And I think, we're always happy if people want to come and watch, see how it's done. You can go on courses, but actually seeing it, and you can then go through 4 or 5 cases with one of us, and we'll just show you the little tips and tricks, and then, you can start using it yourself.
That's great, thank you. And Ozan's asking about the posterior limit for intracapsular tonsillectomy, anterior pillar, etc. I think you probably answered that, hopefully.
Yeah, you just keep the pillars tethered with your forceps closed. So I just use those to just kind of push the tissue, just to show me what I'm doing. And then you can move the tissue with a non-coblating hand, and the coblating hand just go backwards and forwards, and essentially just a bit like using a mastoid drill, where you've got the option of rotating the patient backwards and forwards, almost to just go around your drill. So it's very, very easy from that point of view, just with a bit of practice.
Great. And another question is the coblator blade reusable?
No, there are some countries where they try and clean these things, but it's designed for single use. And I think the fact that it's got a lumen, it's quite hard to clean it. You've got to think about the risk of prion disease and various other things. So I think, there are centres where you can get things sterilised in some countries, even in some, where you think was a very sort of fancy country or highly developed countries, they still try and sterilise instruments. But it's not, it wouldn't be done in the UK. It's not recommended by the company.
Great. And there's another question. There's a few questions, sorry, Dan. A few more questions I'll ask you. Have you seen any accessory tonsil pockets caused issue after intracapsular tonsillectomy?
A little holes left behind, I presume, where you have risk of, say, tonsillar lifts and whatever. That does happen. Patients with tonsillar lifts, strangely enough, are a difficult group to manage. So often they don't have symptoms which are bad enough to warrant traditional extracapsular tonsillectomy, because to have a risk of readmission as an adult of almost 1 in 5 patients just because of tonsil stones is quite a big deal. So intracapsular tonsillectomy, you think, would be the answer, but actually often these guys will have little pockets actually through the capsule. So the capsule will be there, and you have like a little hole in the capsule where the tonsil, so though you can expose that hole, you can still trap debris. I mean, it's something you just have to be aware of and explain to the patient. again, you're aiming for an excellent result, but at the same time, no operation is perfect. And what you're trying to do is a balance between safety and efficacy. And also you have to be able to put your foot down when you have people say, no, I just want traditional surgery. I don't want a tonsil stone coming back, and say, I would say in my own practice, I'm not prepared to offer that because I don't think the risks are justified. And often those patients are a little bit peculiar. So they may have, they may be absolutely obsessed with their tonsil stones and their bad breath, and a bit like the rhinoplasty patients that you're frightened of because they just come across, unusually. Be aware it's your choice to operate on them. They might complain that you didn't want to operate on them, so be it. You just don't put yourself in that position.
Yeah, thank you. And another question is how to overcome clogging problem of the probe.
Yeah, so use enough saline and use enough suction. One of the commonest things is that the setting of the saline needs to be drip, 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 almost continuous flow in the giving set. You see that little reservoir, and it should almost be a continuous amount. And the suction has to be turned on full. Where you go wrong, you have, and always have a little dish of saline on the trolley that you can then use. Where they go wrong is they put water in that dish. They use the wrong medium, dextrose, for example. If you're just starting out, you need to use normal saline. Plenty of flow and suction turned up to the max, not somewhere near the maximum, but completely maximum. And then you reduce the risk of clogging.
Great. And somebody else asks about how do you find intracapsular compared to extracapsular tonsillectomy?
Fantastic. So, I mean, I perform very, very few extracapsular tonsillectomies. I sometimes have some, there's remnant patients that have to have a dissection. It fills me with horror. So I saw a 2-year-old who had had some recurrent symptoms in those residues, and we offered him a revision surgery, and he weighs 10 kilos. And I gave him tranexamic acid afterwards, and I just thought this can be really, really painful. And it's a necessary ill in some cases, but I'm very, very pleased I don't have to offer that most of the time. You're operating sometimes on very high risk children who are the only child of a family. I've got a patient whose mother, he was 3 years old, his mother was 58 years old, her only child, no other next of kin. It's a massive pressure. The child had sleep apnea. I can't send them to anyone else. I've got to operate on them. And I want to do something where I can sleep at night. And I know, touch wood, that the child's not going to die as a result of what I've done. So I take it really seriously. And I think it's important to get that across. You all you have to do is Google deaths after tonsillectomy, and you see some shocking things. My child had tonsillitis. They're 5 years old, went for an operation and dropped dead. They weren't even resuscitatable before the ambulance came. I mean, it's awful.
Yeah. Another few questions from Ali again. He's just asking about the follow-up setup at the Evelina.
I just follow up all my patients. I don't care. I put them all down for follow-up, and I keep all their T14 forms and a copy of the discharge letter in a folder, sort of carefully in the trust. And if they haven't been followed up, I just follow them up myself.
That's your follow-up, particularly because you're following them up quite extensively up to 5 years. I
don't ring up. I wouldn't pester people. There happen to be those cases up to 5 years or more have been ones where I've seen maybe a sibling, or they come about grommets, or they come about something else, and I happen to take and use that situation to find out a bit how things are going in an audit, using an audit tool. So these are recognized audit tools. It's not a research study where I'm comparing one thing to another, or so we haven't had to have specific ethical approval, but I'm conscious that they're patients who are just going about their business, and I don't harangue them. And in fact, no one has ever been upset to be telephoned as a follow-up to check that they're okay. People see it as a mark of someone that cares about them, and it's amazing. The more people you call up and ask how they are, the more happy they are. It's part of your job as a surgeon to find out what you're doing is right.
Yeah.
And it's mandatory if you're doing something new. Otherwise, you don't know what's going on.
Yeah, and it's been very helpful to guide things for the future. Somebody else is asking, any date on revision rate for coblation adenoidectomy?
Yes. So, what's slightly tricky is because we do adenoidectomy with different methods. I started initially using suction diathermy because I felt more comfortable with it, and I started using coblation maybe after about a few hundred cases. Now I use it almost exclusively. The revision rate of adenoidectomy I looked at my particular patients over a period. I mean, it's similar numbers, maybe, I mean, you know, over 1,000, whatever. The revision rate is probably about 3% or so. The reality is that you're often operating on very little children. I say to parents of 2-year-olds, you know, or 1-year-olds, or whoever's having adenoid surgery, children of this age will sometimes graduate to having revision adenoidectomy because they're at the sharp end of the wedge. They're not everyday children. Most children don't have to have an operation like that at age 1 or 2. And if you're operating on those kind of patients, they're going to come back in some proportion. So either have revision adenoidectomy or they have revision adenoidectomy plus or minus tonsillectomy when they get older. It's, you know, it's a reasonably common theme. It's not something that puts me off. And you know, you also hear some crazy sort of management where people haven't had an operation because the surgeon said your symptoms might come back, so I'm not going to operate on you. I mean, you know, nonsense. You know, if the patient's got symptoms, they need to have an operation. If you've got such gentle procedures, I mean, look at, there's a study from Brighton, and their complication rate after suction diathermy adenoidectomy is like 0 readmissions in 3,000 or 4,000 cases. I mean, it's just, you know, it's a no-brainer. And coblation, you get very, very gentle, similar sort of results.
There's a question from Peter about what is the regrowth rate with coblation technique versus, I'm not sure what that word is, of adenoids.
Curette?
Curette, probably curette, yep, of
I think
adenoids.
that's guillotine, but
I
Okay.
don't know, because I haven't done a comparative study, and you will have, in all these kind of forums, there always someone says, I have never had a regrowth of adenoidectomy from adenoids in 20 years of practice. And I just find that impossible. I mean, some of the results that people come out with, I find impossible to believe, because it's not going to be the case. You're not going to have 0%. So I think what you're trying to do is just think, how are you going to get this child through an operation quickly, efficiently, and safely? And a curette has, sure, it can work in expert hands quite quickly, but it's one of the most sort of anxiety-reducing operations that you have when you're starting in ENT, because the consultant looks like they've just chopped out a huge thing. It bleeds everywhere. They put a pack in. They say, right, you do it next time. You think, oh my God. And you fiddle around and it bleeds everywhere, and then you've left all the adenoids behind. There is no other operation where no direct view is obtained, and you're doing something which can cause torrential hemorrhage. I've seen patients in PICU when I was an SHO packed with big postnasal packs and so on, and we just don't see that with these electrical methods. So I don't know the difference in recurrence, but it's something that's just easy to do, which can take as little as kind of 90 seconds to do the whole adenoidectomy, including stopping the bleeding and everything. I couldn't go back to using curette. And in fact, I've only done about 10 cases, so I would consider myself inexpert to use a curette. Although there are people that say it's good, but again, is it generalizable? Same with bipolar tonsillectomy, same with these extracapsular methods. You'll have experts you come across who work in paediatric centers that I know my bleeding rate is 1 in 100 patients, or it's 1.5 in 100. Great. I mean, you know, they're people I believe, they're people I work with, I know names throughout the world in ENT, but can you generalize that to the district hospital nearby, or the other colleagues in the teaching hospital near you, or the person that does 3 tonsils and 4 adenoids in a month? They have to do those 3 tonsils and 4 adenoids. We can't do all of the work, or other centers can't do all of the work. But you can't generalize, you're trying to use a method which is replicatable amongst the more occasional operator. It's not like thyroid surgery or mastoid surgery you can just send to a specialist, because there's just too many of the operations.
Yeah, and that links into another question. How widespread is coblation for tonsillectomy in the UK at the moment?
Intracapsular, it's becoming much more widespread. I mean, it had been used a little bit, but not published. And we published our work, first couple of papers, and loads of big centers start using. So we use it almost as in it's almost our exclusive method of tonsil surgery in our center, where we're looking after around 1,000 patients a year. It's become very popular in places like Manchester and Great Ormond Street and Bristol and Birmingham, all around the country. Newcastle, places which were using bipolar or cold steel or other things have just cottoned on. And once you get started, it's like night and day. I mean, the patients recover really well. It fills you with no dread. I mean, once you're over that period of being a bit inefficient, it's a fantastic operation.
Great. I think somebody asked about indications in case of halitosis, but I think you've answered that with regards to the tonsillectomy.
Yeah, I mean, I'm a bit dubious, because everyone's got, I mean, even Tom Cruise has got bad breath, almost certainly. And if he puts his finger down his throat, just like all of us, it's going to smell. And to remove your tonsils, to get rid of that, I mean, you've got your tongue base, you've got all the other areas which are going to accumulate bacteria. And I try and send patients to an oral medicine specialist and run away, basically, because they're going to be a problem afterwards.
Great. And last question, any risk of scar, contraction and stenosis of nasopharynx after adenoidectomy?
I've never seen it in my patients. I mean, we talked about never in medicine, someone saying I've never had a complicate or I've never had a regrowth. I haven't seen it as a problem with my patients. I'm very gentle with adenoidectomy. I take the stuff around the choanal, often leave a good wedge of tissue at the back for the palate to close against. But the methods we use, I mean, particularly with coblation, it's so gentle. You see that particularly with the pharynx, and you could translate that into the adenoid area. With traditional tonsillectomy, you'll almost see a very, very box-shaped pharynx where everything's scarred up. You almost have no definable pillars anymore. Everything's just pulled up because it's been basically barbecued. Whereas with the coblation, you just see a beautiful, supple pharynx, the uvula. So I've looked after, people who are amateur or even professional singers and things like that, or teenagers who are in stage school or goodness knows what. And they have no scarring at all. I mean, it's a brilliant thing about it. One of the brilliant things about it, you don't get any injury like